As I go through life, it's an endless stream of special moments and hopes and dreams. I hear a song and it calls to me about the ones I love, friends and family. It's always good to know I'm on my way home. I got you on my mind wherever I roam. So many ups and downs, but there's one thing I know. I'll be with you soon, I'm on my way home. I'll be with you soon, I'm on my way home.
Hello, everyone, and welcome to this Axxess LinkedIn Live conversation. We are so glad that you're here, and we are using conversations like this to bring you meaningful discussions on a variety of topics. We hope you learn something from the experts you meet along the way in these Axxess LinkedIn Live events, and we encourage you to join the conversation in the comments or ask questions you might have. We'll do our best to keep up with those as we have this conversation. My name is Tim Ingram, and I work on the business development team at Axxess. And today we're going to talk about important changes from the 2021 Home Health Final Rule on a practical level. And let me introduce you to our expert. I'm joined this morning by Arlene Maxim, who is Vice Chair for the Association for Home Care and Hospice Coding and Compliance, and she also serves as a business consultant with Axxess. Good morning, Arlene. How are you doing today?
Well, good morning, Tim. Thank you for having me.
Yes. So let's dive right in. We're going to hopefully have some back and forth, and we'll do our best to pay attention to the questions, as I said. Axxess has held webinars on the no-pay RAP, Request for Anticipated Payment, or RAP as it's called, and the 2021 Home Health Final Rule changes, and both of those were very well attended. What we noticed was that we had a lot of questions from home health clinicians. Arlene, you're a registered nurse with, let's just say, more than 20 years experience in the field. Tell us, in your experience, why is it so important for clinicians to know these rules that might seem like they only affect the billing department?
Well, thank you, Tim. And I want to thank Axxess for taking the time to get the clinicians involved in the educational pieces that we do here at Axxess. And yes, I think that one of the things that these clinicians need to know is that it's so important that they understand this new ruling, because they're going to be an integral part in making sure that it's successful for the agency. The RAP issue, and I'm not even sure that all clinicians understand the entire RAP process, but for the past 20 years, we've had a request for anticipated payment. And that request allowed the home care agency to get money, about 60% of their cash, up front so that they could pay the employees and that kind of thing and do their operations. Well, with PDGM, that all changed, and the PDGM rule allowed us now to have a decrease in the RAP payment. So we only, last year in 2020, we only received 20% upfront, and then this year we are going to receive no money upfront. So it'll be really important for the clinicians to understand what their role is in making sure achieving this no-pay RAP goal, and making sure that the agency has cash to continue to function. I always tell clinicians that without a healthy home care agency, we don't have employees and we can't take care of our patients. So it's really important that we understand what the revenue chain is and how they can take part in making sure that happens.
So when the final rule changes begin in January, it will have only been a year since the implementation of PDGM, or the patient-driven groupings model. This was the first major change in billing in, 20 years, I believe. Now the rules are already changing again. I think it would be beneficial for clinicians to understand why their workflow is being altered again and what purpose it serves. Can you maybe tell us why CMS chose to implement these changes so quickly? And should we as an industry, should clinicians buckle up for more changes like this in the near future?
Well, Tim, in the more than 30 years that I've been in this industry, I found that change is just something we live with every single day. So we can always expect change. Now we have a potential for a new administration coming in, so there certainly are going to be changes because the potential director for HHS is someone who's been very involved in different types of litigation and that kind of thing. So medical reviews and those types of things will be the things that will be impacting our industry. But as far as this is concerned, the no pay wraps, I think that what the clinicians need to understand that this is just a continuation of the PDGM process that we saw be implemented in January 2020, and that was a plan. This has been always the plan. We had 20%, as I said, of cash coming in at the beginning in 2020. At this point, starting January 1st, so we have a little time to prepare. We will then see no cash coming in. But what's really important is the staff understand that the no pay wrap situation is going to be only around for a year. So in 2021, we are going to see something called a NOA, which is very similar to the NOE. It's Notice of Admission, where we will have an opportunity, information about the patient at admission. We will not have any financial benefit as we are right now with the no pay wrap, but there will be less paperwork probably as far as administratively in the year 2022. But we will obviously see changes upcoming probably for the foreseeable future.
Okay, so you've mentioned some of them already, but let's get down to it. What are the major changes that will begin in January?
Well, I don't think the major change here is the no pay wrap. And I think that's the one thing that the clinicians really, really need to be aware of and what their role is in making sure that this no pay wrap process actually works, because they're going to be a very, very important part for administration. And I know that clinicians many times don't want to hear about billing, and many of us come from hospital settings and institutional settings, so we don't really hear about financial woes and that kind of thing. When we get into home health care, we're much closer to administration. So we have to understand what's going on in billing. We have to understand what our responsibilities are. So it's important that they understand that their responsibility is going to have to be the documentation. This has always been an issue. The documentation is going to be the key to the success of this part of the no pay wrap situation.
So you, being a clinician with a lot of experience in the field, you understand the day-to-day routine of the home health clinicians. What do you think will be the most difficult change to implement, and maybe some tips on how they can overcome that?
Okay, so there's a couple things that I'd really like to point out for the nurses and therapists, because therapists now, with the waiver as a result of COVID-19, the therapists are also doing a number of these start of care assessments. So a couple things we need to understand is that we have to have, there are four things actually that we need to really, the clinicians need to understand. One is that we have to have a non-billable visit, billable submitted within the first 5 days of the start of care. The start of care, and I think most clinicians understand this, the start of care is counted as day 0. So we actually have 6 days. Now, the kicker here is that we also have to have an approval from CMS and the Common Working File, which clinicians don't really need to worry about, but we have to have approval within that 5 days as well. So it'll be really, really important for the clinicians to get their documentation in within 3 days. Now, I would also recommend that you talk to your administrators. I don't want to try to implement policies for you all just as an individual, but I think you need to talk to your administrators and see what their plan is for going forward with this. We have to have a verbal order from the physician, so it'll be really important for the nurse to get that verbal order from the doctor And if they have other processes within the organization, then that process will have to be followed. But I just want to be very clear that you need to talk to your administration, find out what policy changes have been made, make sure you get your documentation in on time. The difference between a start of care assessment and Oasis assessment are the start of care assessment is where you determine eligibility, you determine whether the patient really is a Part A beneficiary, and you get all of your consent signed, but you have to do a billable visit. So let's go back to my second point where we talked about physician's orders. The physician order has to contain all of the services that are required during that first billing period, that first 30 days. So with that being said, if that's true, then on your first visit, you have to have an order for that billable visit. Now, it's important for the clinicians to understand what a billable visit is. So it could be something as simple as wound care, it could be teaching medications, it could be teaching the diagnosis process, but you have to have an order for that. So simply having an order for services the first time around is not going to be sufficient. You're going to have an order for services. Your Oasis information and your integrated assessment can also be completed within that 5 days. Now, if you do a second visit within that 5 days, the clinicians will have to do a second billable visit. So you make sure that you have orders for that second billable visit. So I think that those are the biggest things that the clinicians really need to understand, that this is not business as usual. We have a tight time frame, and if we don't do our job as clinicians, then the agency is not going to be able to do very well financially.
So not just accurate, but also timely documentation and submission of that documentation is one of the key things I hear. So I mentioned earlier that we're approaching this from a practical level for clinicians. And with your experience going into 2021, let's say they're going to be seeing a patient for the very first time. In 2021, what should they do that maybe they haven't done in the past? And then what should they maybe not have to do that they did in the past?
Okay, so you're right. This will be a big change, and so the thing that they really need to focus on is getting that first billable visit into the documentation for that into the clinician. Now, my recommendation for a number of years has been to do point of care documentation. We need to use our computers for what they were meant for. We need to use our EMR for what they were meant for. I do know that there are a number of agencies that are still on paper. That's going to be a little more difficult, I believe, than the agencies that do have an EMR. So I would highly recommend, if you don't have an EMR right now or one that's working practically for you, that you take a look at one and try to get involved in one, because this is going to be, I think, difficult to actually get that documentation in on time. You hear nurses all the time saying their start of care assessment takes them 2 hours. We're not going to have the time to get all the documentation in and then get it turned into the operation within that 3 days if we aren't very studious about getting all that documentation done. So again, I highly recommend that the clinicians speak to their administration, find out what policies have changed, and find out what they recommend that they do as far as timeliness of the documentation. And don't lose sight of the fact that CM or your Medicare payer is going to have to acknowledge that and approve the non-pay within that same 5 days. So the nurses and the therapists do not have 5 days to get their start of care assessment, and they have a much shorter time.
Right. We do have, I noticed we do have a question in the chat. So let me ask you that. I think now is a good time to ask that. And Kathleen asks, is a verbal order that is documented and added to the POC allowable for the verbal order for home health?
It is. The verbal order is all we need, but that's what I want to make very clear, that the verbal order has to contain not only the services that are going to be provided during the episode, but also the billable visit information. So what is it that you're going to do? What is it that's billable? The Medicare Beneficiary Policy Manual in Chapter 7 will list those out for you. So if you're not familiar with those, I would highly recommend the clinicians take a look at those and find out what is billable. For nurses, we have 15 items that are billable, and I think most nurses don't know that. For therapists, it's a little easier because therapies primarily do things that they typically do in institutions, so it's not as difficult for them to understand what is billable and what isn't. But I think it's going to be very important that clinicians understand that every piece of their documentation they're submitting now is likely to go under review by the MAC within the 6 months. I see in 6 months we're going to have a lot of medical reviews coming forward, and to see if we actually followed the process that the CMS has implemented for us. So I think it's important that your documentation be very, very good, and that you show that you actually did the billable visit, that you've acknowledged the eligibility for the patient, and that you have all the other items that Medicare is requiring.
Okay, good points. Thank you, Arlene. We did receive a number of questions at some of our webinars from clinicians, and I believe some of those would be appropriate for us to talk about again. And the first one is, does an Oasis and assigned plan of care need to be completed to bill the first wrap, and is that considered a billable service?
Yeah, that's a really good question, Tim. And the good news is that no, the Oasis does not have to be completed before we submit information for a non-pay bill wrap. The plan of care as well is not required, and I think that's a really good thing for us, that we aren't going to be pushed to the point where we run out of time to get that. And that's another warning I would like to give to clinicians as far as this is concerned. If you are if your agency is supporting completing the Oasis within the 3 days, be very, very sure that you're not shortcutting yourself and that you're getting all of the integrated information into your Oasis, that it's an individualized document, that we have enough information, that we have an appropriate plan of care. We don't want to go through this quickly and just check boxes. This has to be done just as thoroughly as we have been doing with the 5-day time frame that we've had in the past. We can separate those. We can have a start of care visit, and then we can have an Oasis completion visit, which would be that MO90 number on the Oasis that shows completion. But be very sure you're following agency policy and that you are doing a very thorough job on your Oasis assessment.
Good tips. Thank you. So because of the number of questions that we've received from clinicians, we actually created a no pay wrap FAQ page on our website, and we'll share that link in the comments so that any clinicians attending can find answers in an easy to use format and read at your own pace, if you will. So Arlene, while I don't have field nursing experience, I do have healthcare and operations experience for home health. And I remember having or being part of, I guess for lack of a better term, a give and take relationship between clinicians in the field and the office staff. So how do you think these two teams, the field clinicians and the office, can work together in the best way to make sure that we are, as organizations, meeting a shared goal of compliance?
I got to tell you, Tim, that's a really, really good point that you've made. And the best thing I can tell you is communication. The communication between billing staff. I believe, and I've been instructing the agencies that I work with as far as consulting, I've been trying to instruct them to make a change in their intake department and try to get as much information as you can during intake. The intake department can gather an awful lot of information that the clinician can have when they do their start of care, which will be very, very helpful with these short time frames that we have. So your intake department can get your verbal order, probably get your verbal order as long as you have a clinician in your intake department. And we can get a lot of information to get you started. We can get information about the homebound status of the patient. Another thing to make sure of is that you really understand what the eligibility criteria are for determining whether or not a patient has eligibility for home care in general. But as far as working with the office staff, administrative staff and billing, the communication is going to be the key to the success of this no pay wrap situation. And know that this is only going to go on for 1 year. We have had, like I said, a number of changes, but this situation with the expedited documentation, that type of thing, we see this as being only a 1 year challenge. And also, I've heard a number of agencies me about there being a grace period due to COVID, and whether or not they'll push this off, like ICD-10 and some other things, but there will be no grace period here. We see Oasis-E coming down in 2022 or 23. Those are some other big changes that we'll have. But as far as this no pay wrap situation, getting your documentation in a timely manner and that type of thing, that's not going to go away. And you need to be ready for that in just a couple weeks. January 1st, it starts, and we're not going to have time to practice. We're not going to have time to see if it works. You will have to get this done on January 1st.
Yep. Great tips, Arlene, and good reminders for what should be standard operating procedure. So we've got some more questions. I believe it's scrolled up a little bit, but I believe this question comes from Paul. And Paul says, so as I understand, the Oasis needs to be submitted in iKeys within 5 days. Is that correct, Arlene?
Well, those timeframes have not changed. I believe there was an extension with a waiver, but the 5-day period is when you should try to get those Oasis documents in. Yes.
Okay. And then another question from Cindy, who asks, does the start of care or the SOC Oasis have to be completed before the deadline, or just documentation that the billable visit has been made?
Only documentation that the billable visit has been made. Now, I've had agencies say to me that they are going to have the clinician call to the office to say that they've made a billable visit. My advice for the agency is to get their hands on that document to show that they have a billable visit. As I said earlier, my belief is that we are going to see an influx of medical reviews, very similar to what we saw with face-to-face, where they looked at 5 records to see if we were actually following the rule. My belief is that we'll see that again. So we will have to show that we had that billable visit. I would also recommend that there be some type of tracking going on. And I know that Axxess in their EMR has put a number of tools in for no pay wraps. So that's a thing. So it would be important for the clinicians to find out what their EMR has to offer as far as that's concerned.
Okay, good tips. Thank you. We have some more questions. The next one is, can the order for home health be from an NP or PA?
That's a really good question. With the waiver, waivers, they have allowed the nurse practitioners, as far as federal standards, to actually do that. Now, there have been some changes. There was actually a change that came up in May. I would encourage you, I don't have that in front of me right now. I can actually get you the reference for that information. You will need to check with your state to see if the nurse practitioners or PA can actually follow through with that. Federal guidelines say yes, but if your state does not allow that, and there's many states that do not, then you will not be able to have the nurse practitioners or the PAs sign those documents.
Got it. Oh, okay, and then we've got another question from Claudia, who says, Claudia's under the understanding that we do not have to submit an Oasis. So I think there is some confusion around that. Do we still have to submit the Oasis in 2021?
Submit the Oasis in 20, well, you will have to submit the Oasis, but you don't have to do it within the short time frame. And I guess I think that's the key point, and I think that's what everybody needs to understand. The Oasis does not have to be completed within that 5 days. But again, make sure that you check with your agency administration and find out what their policy is, because those policies have had to change, hopefully, as a result of this. And you need to make sure that understand what that policy is and you're following your agency policy. If you're working for multiple agencies as a clinician, you need to check about the policy for each one, because some of them will require an entire Oasis. Some of them are simply going to require the billable visit. Whatever you do, make sure you have an order for it, and that your orders don't necessarily need to be signed. They just need to be the verbal order.
Got it. Okay, and we've got another question, and I hope I'm getting to all of these in the chat. There's been a flurry of them come in. Jessica asks, the weekend counts as the 5-day frame to submit the wrap, correct? I think that's a great question. What about the weekend and counting the 5 days?
Yeah, it does. That's a really good question. Thank you, Jessica, for asking that. It does count for the 5 days, so that timeliness is going to be even more important in counting those days within the 5. The other thing I want to bring up is it's come to our attention, and maybe some of you knew this and I didn't, I missed this somehow, but many of the MACs, so for instance, we have Palmetto, we have NGS, we have CGS, many of the MACs close their doors early in the day. And so that means that you get this information in prior to that time. The one I know about is NGS, and NGS requires everything in by 3:30 Pacific time. So if you don't get it in prior to that, then you've got a major problem. So the timeliness is also an issue. And I've also recommended that agencies check with their MACs to find out what that time cutoff is, because that's really, really important that we know that and know that maybe we have a shorter time frame than we thought we did. So that's something to check. Thank you, Jessica, for the question. That was very good.
Right. Right. Here's another question. And for those listening, I apologize if I'm missing. We've got a flurry of questions coming in, so we'll do our best to get all of these answered before our time is up. Patricia asks, my intake enters the primary PDGM diagnosis code. Sometimes that has to be corrected by the coder. Will I need to resubmit a corrected wrap? Great. Another great question.
That's a really good question. Yes, no, you won't. That's different for us, isn't it? It's something different. The code should be close. And that was something else that I want to make sure that we mention here. And I'm glad you brought that up, Claudia. The code does not have to be exactly the same as you're going to use on your final claim, but it should be close. I can see, again, when I mention medical reviews, I can see that some of that, although there's not really matching going on any longer, I can see that some of the MACs may have questions, and it's just not Medicare that we need to be concerned about, because we have these SIO audits, we have all kinds of audits going on, and some of them have rules that are a little ambiguous. So having those codes as close to the code you're going to use for the no-pay wrap will be good, but it does not have to be exact.
Got it. Okay. And Lynn, I believe it was Lynn who asked another good question. Well, let me scroll. I've lost that one. Sorry. And thank you so much. We will do our best to answer all of the questions that come in. We'll try to get back with everyone and compile these questions and get you answers. There's some great questions. Here's another one from Martha. And Lynn, I apologize. Your question has disappeared from my screen. But Martha asks, so just to be clear, there must be a billable visit within 5 days after the start of care, correct?
That's correct. A billable visit within the 5 days of the start of care. However, remember that 5 days also includes to a lack of a better term, the MAC, the Medicare contractor, to approve the billable codes. That's not something the nurse or the therapist needs to be concerned about, but that 5 days includes that. So as far as the clinician, it's going to be important that you get that information into your agency within 3 days. And that eligibility and the fact that the patient's being admitted, all of those items have to be clearly documented. And that's not necessarily going to be the documentation on the Oasis. It's documentation you're going to have to have in that first note. If your agency requires you to do a complete assessment, then it'll have to be in there as well.
Got it. Okay. Here's another good question from Cindy. And Cindy, thank you. I believe this is the second question you've asked. What about research? How does this affect research?
Well, you'll actually have to get a billable visit in so that the RAP can be submitted for the research. However, let's back up a minute. Now we have 30-day billing cycles that we have in the first episode. So both RAPs can be submitted at the same time. So that's a billing issue that really the clinician doesn't need to be worried about. You need to make sure that you get that first billable visit in.
Okay, got it. And Carol asks, you mentioned 2 types of visits. I think this is a great topic to revisit to make sure everyone is clear. Carol asks, you mentioned 2 types of visits. Can you clarify the difference between start of care visit and an Oasis visit? Another great question.
Yeah. Yes, and that is confusing. And again, it really depends on your policy. But as far as Medicare is concerned, your start of care visit is a visit that's different than your Oasis assessment and your integrated assessment. So your start of care visit is when you find the eligibility criteria has been met with the patient being homebound, that they need skilled nursing care, aid services on an intermittent basis, that they have a need for therapy on an ongoing basis, that you have a doctor's order, that you have a physician who's going to follow this patient, and that you have face-to-face. So those criteria have to be met during that start of care visit. You need to give the patient their rights. They need to be signing their consents and all of those things you do with your initial visit. But it isn't necessarily the complete Oasis integrated assessment visit. So you still have that time frame, that extended time frame for that to be completed, but you do have to do something called a billable visit. And as I mentioned, if you look in the Medicare policy manual, and again, we can provide a link for that if you would like, you need to make sure that you provide a billable visit, and that billable visit also needs to be ordered on that verbal order that lists the services that are going to be provided. So that's something that CMS will be looking for if they ever take a look at or audit these claims. I would guess that your surveyor in 2021 is also going to look for these things. I hope that's clear. It's really difficult because some people believe in their heart that the Oasis visit is the start of care visit, and that's not so. The start of care visit is eligibility and performing probably a quick assessment to find out what the patient's immediate needs are, and then we can complete our Oasis assessment at a different time as long as MO90 gives. Yes.
Okay, and keeping with the Oasis theme, we have another question from Diana. Did the time frame for exporting Oasis change?
It does not. The exporting time frame has not changed. But the key for exporting, but it doesn't have to be exported prior to delivering the no pay wrap to the MAC, and that's what's important, because you won't have to quickly go through that. I think it's really so important that clinicians understand how specific you need to be in Oasis, and Oasis is not something you just check boxes with. You need to take your time with it, and you need to make sure you have complete documentation with an integrated assessment, and that you actually paint a picture of your patient with that. So I don't want you trying to, as far my personal view is that you shouldn't try to rush through the Oasis process just to get it done within a couple days. But it's really, really important cash flow wise that you get a billable visit into that agency within that 3 days.
Right. Here's another, this is interesting. Someone is paying attention to the HIPs, which Arlene, you and I discussed that before this call. Can the HIPs be different from the initial submission versus the EOE, the end of episode submission?
Yes, and as Tim and I had a conversation about this earlier prior to this session, yes, code can. Some agencies are saying, and I think that some of the actual national and state associations are recommending that you use a generic HIPS code. However, again, I think we may run into problems with that with an audit. I don't think that's something that clinicians really are concerned about. But no, the HIPS I have to be the same as CMS has said they're going to take care of that for us.
Got it. Okay. And we do have another question from Patricia. What would cause a RAP to be unbilled in an EMR? I'm not sure that we can provide an exact answer for this one since EMRs vary, but let me see if you've got a good way to respond to this, Arlene. What would cause a RAP to be unbilled in an EMR? There should be no auto cancellation of RAPs now, correct?
Well, I guess it's not your EMR that makes the decision whether or not that RAP is going to be accepted. It's a common working file process. Maybe I could try to respond to that in writing and get a better answer for you for that. I don't know, but I quite understand the question.
Yeah, I think that's a good idea. Okay, and we have another question from Maria, and we should probably make this our last question. Again, for those who have submitted questions, thank you so much for your interest and your questions. We've had some great questions, but I believe we should make this the last question. And then, as I mentioned, we will try to get back to you and answer all the questions that have been asked. So another question is a telehealth visit sufficient for a face-to-face encounter documentation?
The telehealth, as far as the physician is concerned, as long as it includes video and they can actually talk to the patient, they are allowing that. But that's a physician billable issue. It's not home care necessarily, but it is acceptable if they have the video visit. Yes.
Okay, good. Arlene, this has been a fantastic discussion. I'm so appreciative of the time you've spent with us today. And as I mentioned, Axxess has produced 2 very informative webinars on the no pay RAP and the 2021 home health final rule changes, as well as our frequently asked questions, or our FAQ sheet. And we will share those links in the comments here. Thank you all so much for joining. I know your time is valuable, and we're appreciative of the time you've spent with us for this Axxess LinkedIn Live conversation. We will bring you more discussions like this in the near future, so please stay tuned to our LinkedIn page for our next broadcast. And in the meantime, if you want to learn more about Axxess, you can find us and information about our enterprise solutions at axxess.com. Thank you again, and we hope everyone has a great day.
Thank you, Tim.
It's always good to know I'm on my way home. I got you on my mind wherever I roam. So many ups and downs, but there's one thing I know. I'll be with you soon, I'm on my way home. I'll be with you soon, I'm on my way home.